Now, I'm going to blow your mind. Watch this. How do you figure out if a drug is going to behave like a fat soluble drug or a water soluble drug? How do you know? There are millions of drugs. How do you know? All right. Here's what I want you to do. I'm going to give you about 10 years and I want you to go research all million drugs. Come back to me in about 10 years with your report. Meanwhile, my patient's dead. But what if I could show you, you could figure out every drug in about 5 seconds? Would that be kind of cool? Okay, watch this. In 5 seconds, you'll be able to figure out, is this drug going to be a water soluble drug or a fat soluble drug? Watch this. Because those are our options. It either works on water, it likes water, or it likes fat. Check this out. I'm about to blow your mind. There's one question that you must know the answer to quickly come up with this. How many questions? So there are all kinds of things you could ask about a drug. Give me some things that you could potentially know about a drug. This is the stuff people try to memorize off a list. Oh, what's the class of the drug? What is the mechanism of action? Mechanism of action is extremely important because that's how the drug works. Okay, the class of the drug, that's just telling you what the result is primarily. Is it a venodilator, a vasodilator, a phosphodiesterase inhibitor, a 5-HT receptor antagonist, whatever. Acetylcholine agonist, acetylcholine receptor antagonist, stuff like that. So we have the class, we have the mechanism. People know things like indication, contraindication, side effects, dose, the route of administration, stuff like that. Well, this is stuff that people try to memorize. They'll have these little tables of information. But do you know that there is no one book on the planet that has all the information about every drug? So imagine if you went to EMT school, you went to paramedic school, you went to nursing school, you went to medical school, and you only read your one book on pharmacology. That one book does not have all the information, right? I didn't know this in EMT school. I didn't know this in paramedic school. Nobody told me this. I didn't know this in medical school. I only found this out once I had a mentor. So I had gone through medical school. I was studying for my board exams. I needed some help because especially the basic sciences, the first 2 years of medical school, you have to, after 2 years, you take one test that's hours long for 2 years worth of information. Well, medical school is intense. I mean, like every single day, you're getting 4, 5, 6 lectures a day for 2 years. And imagine taking all of that and putting it in one test. You can see why I was overwhelmed. So I found a guy. I'm in Illinois. I found a guy who would become my mentor. He would become like a dad to me, Dr. Francis Ihejirika, this Nigerian guy, a med peds doctor, so internal medicine, pediatrics. And I came under Dr. Francis's wing. He kind of mentored me. He's still a mentor to this day. We met a few years back, and Dr. Francis showed me what I'm about to show you, and it changed my life. It changed how I approach medicine. Suddenly, he was showing me patterns in medicine. Dr. Francis said this. He said, you need to go back to normal. You need to understand normal. Don't try to understand abnormal. Understand normal. Because when you understand normal, abnormal will just, as he said, it'll just smack you in the face. Okay? We want to understand normal. When I know normal well, I can figure out everything pretty quickly. I can figure out things I've never even read before just because I know normal. Okay, watch this. There's one question you need to ask. All of this information is great information, but if I need to know, is this drug, there's one question that's more important than all the other questions. To help me determine, is this a water soluble drug? Is this a fat soluble drug? There's one question I need to know the answer to. That one question is, how often? What? How often? How often do you give the drug? That's all you got to tell me. I don't need to know the name of the drug. I don't know how to spell the drug. I need to know how often is this drug given. And so if I ask a pharmacist or if I ask somebody that, they don't know that I know this information. So they'll gladly give it to me. Oh, yeah, you're going to give the drug every 4 hours, every 6 hours, every 8 hours, every 12 hours. Oh, you're going to give that drug once a month. You're going to give it every 3 months. Once you tell me that, I'm off to the races. I now know side effects. I know toxicity. I know a whole lot of stuff based on that one question. You ready? You ready to know that? Can I share that with you? Now, I had to pay thousands of dollars to learn this information from my mentor, Dr. Francis. You guys are in a free class tonight. Now, boot camp, I mean, you guys have paid. But for those of you in the coaching free class tonight, you're just getting this information. I'm going to show you this. If you know one question, you'll be able to figure out everything so much faster without struggling. How often is this drug given? If this drug is given, um, let's say let's use like every 4 hours or every 8 hours, every 12 hours. What if it's what if it's once a day? What if it's once a month? What if it's every 3 months? What if it's once a year? Okay. Now, for instance, if a drug is given every 4 hours, does that mean the drug is like, is it being metabolized quickly or is it taking a long time? If you got to give it every 4 hours, is the body using it up quickly or it takes a while? If you got to keep giving it every 4 hours, does that mean it's coming in your body and staying there for a long time or it's coming in and breaking down real quick? What does that mean? It is. So, okay. So, for instance, if it's a drug that's given every 4 hours, every 8 hours, let's throw in 6 hours, 2 to 4 hours, something like that, or even 12 hours. If it's given 12 hours or below, if you have to give it every 12 hours or less than that, it's going to be a water soluble drug. So, it's going to be a fast acting drug that's water soluble. Now, let me tell you the rest of it. There's a whole profile for this. Now, if it's given less than every 12 hours, it's a fast acting drug. That's a quick metabolizing drug. That's why you got to keep giving it so much. Okay? If you give it like every 24 hours or more, so 24 hours is every day. If you give it every day or less often, then it's a slow metabolizing drug that's more fat soluble. Okay? So right now we've said water soluble, fat soluble. The fast acting drugs are more water soluble. The slower acting drugs are more fat soluble. Okay, now watch this. If you have to keep giving it, does that mean that it's staying around in the body or it's not staying and being stored in the body? Type in the chat, boot camp. Say it again. Okay, so it's not stored. It's not stored versus the fat soluble drugs are stored and they're stored primarily in fat. That's why they last so long. Okay? Because they're stored in fat cells. Okay? Now, if it's a fast acting drug that's not stored, it's not going to last long in the body. That means it's not going to go hang out in all these other body parts. We call that volume distribution. Like, how well is it distributed out to all these other places? Well, so volume distribution. If it's not stored, it's going to have a low volume distribution. But if it is stored, it's going to have a high volume distribution. That's just a fancy way of saying how much do you have hanging out somewhere. If it's stored, you got a high amount hanging out. If it's not stored, you got a low amount hanging out. Does that make sense? Now, did you know that just based on what I've told you so far, you're going to be able to figure out stuff I've never even taught you? If it's a water soluble drug that works really quickly, that's not really stored, if you had to guess, What organ do you think would metabolize a water soluble drug versus what organ would primarily metabolize a fat soluble drug? Do you know the organs that metabolize a lot of drugs? Okay. I'm going to give you two choices. We got kidney and we got liver. Okay. Which would you say is in which category, kidney or liver? Do you think kidney is more water or kidney is more fat? Why would you think that though? Why would you think kidney is more water? Well, because kidneys make this stuff called urine, right? Like when you pee. And when you pee, is it like water coming out or is it fat coming out of your pee? It is water. So yes, the kidneys are the metabolizer for more water soluble drugs, and then the liver is the metabolizer for more fat soluble drugs. Wow, that's pretty cool. Now check this out. Okay, so if this drug, if this water soluble drug, well, if this water soluble drug goes to your kidneys, and what if the other thing, let me tell you this. So it's going to behave primarily as an acid. This one's going to behave more as a base. Remember, those are our options. Going back to this, everything has to function like an acid or it has to function like a base. Most things are going to be weak acids. Okay. So going back to the drugs, wait, right here. It's either going to primarily behave like an acid or primarily behave like a base. The other thing is, because this is water soluble, we call that polar. This is called non-polar. Okay. This is also going to be charged. This is going to be uncharged. Now watch this, because this is about to blow your mind. Now, if we have this drug going to the kidneys, because it's water soluble, it likes to go where there's more water. There's water throughout the kidneys. Okay. As blood flow comes through the kidneys now filter, produce urine. There's a whole lot of water throughout the tubular system of the kidneys. Okay. Throughout the nephron. But what if we get too much of this drug going to the kidneys and it behaves like an acid? Do I want a whole lot of acid going to my kidneys? So if I have too much acidosis in this affecting my kidneys, what could I do to neutralize some of this acid? What if I give them water? That water can be in the form of IV fluids. So for instance, if I'm worried about them having kidney damage, what if I give them fluids to neutralize the acid? Okay? Okay. Now, watch this. Let me show you this other thing. What if it's affecting the kidneys? How would I know if it's causing too much damage in the kidneys? Are there any tests of the kidneys that'll tell me information about the kidneys? What if I do a urinalysis? If I look at the urine, is that going to tell me stuff about the kidneys? Absolutely. What if I look at things like BUN and creatinine? What? Yeah, because those are measures of kidney function. Okay. Now, for instance, this fat soluble drug, it's going to primarily affect the liver. How do I know if it's affecting the liver too much? Whoa, why don't I look at liver enzymes? Wait a minute. You mean I could look at liver enzymes to tell if this drug is causing liver damage? Oh, yeah. So what if I do maybe an alanine transaminase level, an ALT? What if I do an aspartate transaminase, an AST? What if I look at the GGT level? Okay. Okay. Obviously, I'm going to want to maybe check out like things like an ammonia level. Okay. So here's what else I want to show you. The water soluble drugs, they're large particles. And because they're large particles, remember all of this goes back down to a cell. Only very teeny tiny particles can get through these channels. So when it comes to things moving, you have very tiny things, and then you have larger holes, and then you have some things they have to be transported across. The tiniest things, they go through what's called a channel. Sodium channel, potassium channel, calcium channel. Those are channels. Those are for very small molecules. Then one level up is what's called pores. So things like sweat. That's why we have sweat pores. You don't hear people say sweat channels because sweat is a larger molecule. So sweat has to go through pores. And then when it's bigger things like proteins, like let's just say proteins, they actually have to go through transporters. Okay. Like for instance, let's say albumin or something like that, or iron. We have transporters for iron. We have transporters for albumin, things like that. Okay. So we have channels, we have pores, we have transporters. Only the smallest things can go through channels. So if you have a very large molecule, look how let's say this channel right here, or let's use this one. Let's say this channel, only a really small thing can slide through this channel. But if I have a bigger molecule, it can't fit through the channel. So check this out. If this big molecule cannot get into the channel, it's going to have a hard time crossing the membrane. So let's put a cell membrane around this. Is this making sense? If this big molecule can't get through this channel, it's going to have a hard time getting across this membrane. Does that make sense? So, if it can't get to the through the membrane, it's less likely to cause damage to the cell. What do I mean by that? Let me go back to where I was. So, a large molecule right here, a large molecule that's water soluble, it has a it's going to okay, if it's a large molecule, is it going to be easy to cross the membrane or hard to cross the membrane? So the question is, a big molecule, does it just easily go across or does it have a hard time getting across? What you got? A large molecule, does it easily cross the membrane? Here, remember, here's our cell. Well, sorry. Well, yeah, we'll say that's a cell. What if this molecule is like huge? Can it easily go across or does it have a hard time getting in? It's going to have a hard time. So a large molecule, watch this. Let me change my pen size. Hold on a second. A large molecule is going to be hard to cross membranes, hard to cross. But what if here's a cell, and what if you have a very small molecule, like these fat solubles? They have small molecules. Is that going to be easy to get across this membrane or hard to get across? Ooh, now watch this. See, all we're doing is we're taking basic concepts and I'm showing you how to apply the pharmacology to basic concepts. But if you don't know the basic concepts, you're just memorizing stuff somebody told you off a list somewhere. Okay? Does that make sense? Now, you want to know this story because this is how we're going to know everything else. Now, watch this. If this small molecule is very easy to cross the membranes, what if it gets into the membrane of the cells of the brain? Can that cause damage to the brain? If it's easy to get into the membrane, could it cause damage once it gets in there? It can. So what kind of damage would we see, or what are signs or symptoms that we would see to let us know that this medicine has made it all the way to the brain? It has crossed over the blood-brain barrier, which is a membrane. How do I know that this medicine has gotten across that blood-brain barrier? Oh, you mean signs and symptoms like confusion, mental dullness, lethargy, sleepiness, somnolence, right? Whoa. Okay. What if it gets across the membrane of a muscle? Oh, wait a minute. Could it cause things like myositis, rhabdomyolysis? Huh. Okay, what if it gets in the membrane of cells in the pancreas? Oh, could it cause pancreatitis? Huh. What if it gets into cells of the liver? Could it cause hepatitis? Okay, now I didn't even tell you what the drug name is. I told you to ask one question and you will know all of that information yourself. Let's go back over it. If it's a water soluble, okay, the question we're going to ask is what? What's the question we ask to quickly categorize every drug? How often do you give it? If they say this drug is given every 4 to 6 hours, what do I know about the drug immediately? Okay, it's water soluble. Is it going to be charged or uncharged? Let's look at the list. It's going to have a charge. Okay. Is it going to be metabolized by the kidney or the liver? Oh, if it's metabolized by the kidney, how do I know if there's kidney damage? Could I check things that deal with the kidney? Oh, so I'm probably going to check a urinalysis, a BUN, creatinine level to tell me if the kidneys are involved. Is it going to be an acid or a base? Ooh, what if there's too much acid? How could I neutralize some of the acid? Oh, I could give fluids, right? And what if the fluids don't work? Then I could do something like bicarb. Now, is that a much better way to understand pharmacology than you just memorizing some list you read 5 years ago? So right now, in real time, I'm able to figure out, like right now on the fly, how do I take care of this patient? I need to know one thing: how often is the drug given? Okay. Now, if this drug, I say, oh, this drug is going to be given every three. Ooh, this drug is given every 3 months. Let's say it's a depot shot or something like that. So for birth control, we're going to give this injection every 3 months. Is that a long acting drug or a short acting drug? It's what? Okay, it's going to be fat soluble. Okay, this depot shot that lasts a long time, is it going to be easily stored or not as easily stored? Easily stored. Is it going to be a large molecule or a small molecule? Ooh, so it's a small molecule that can go anywhere. Could it get in cells of the brain? Could it cross the blood brain barrier? Ooh, so if it gets across the brain, what kind of symptoms would I have once it's in the brain? Altered mental status, confusion, dullness, tiredness, lethargy, somnolence, right? Now, look how fast we're able to come up with signs and symptoms by knowing basic information. But you may not have been taught that a depot shot that's used for birth control can cause altered mental status. But because I know the physiology of the cell, I can tell you, yes, for sure, it can cause altered mental status. Okay. Yes, it could. If it gets into the muscles, it could cause things like rhabdomyolysis. It could cause myositis. If it gets into the pancreas, it could cause pancreatitis. If it gets into the liver, it could cause hepatitis. Okay, look how much information we can come up with that quickly without reading any books, any articles right now, just by knowing the basics of a cell. Is that pretty cool? I know I'm getting excited over here. I wanted to show you something else. Go back to this whole thing about calcium channel blockers. Calcium channel blockers. Remember, I said that calcium, going back to this, calcium is used for depolarization in the atria and depolarization in the, what's the other place? Deep, okay. Ooh, I love it. Calcium is used for depolarization of the atrium and depolarization of the thalamus. Sodium is used for depolarization pretty much everywhere else. However, calcium is the one that's used for contraction of all muscles. So, calcium, watch this. Calcium, I did it in pink, right? So, calcium is used for, we said that calcium is used for depolarization of the atrium or atria and the thalamus. But calcium is used for contraction of all muscles. There are three types of muscles. You have skeletal muscle, you have cardiac muscle, you have smooth muscle. All of those are muscles and they all need calcium to contract. Okay? So calcium is used for depolarization, calcium is used for contraction. Calcium is also used for cell signaling to involve things like neurotransmitters, to involve things like hormones. Okay? Calcium is used for movement. In fact, if anything in your whole body moves, we have to have three things. Anytime anything moves, we need three things. One of them is calcium, another is ATP, another is microtubules. This is what my mentor was able to show me, and how he told me, go back and learn normal for yourself. Medical school didn't teach me all of this. I mean, we learned bits and pieces, but nobody put the story together like my mentor, Dr. Francis. So I owe so much to him. And now I'm honored to be able to teach this same kind of thing to other people. Calcium. We said that calcium is used for depolarization in the atria and the thalamus. If we have too much depolarization, that's going to cause a fast heartbeat in the atria. It's going to cause seizures in the thalamus. In the gut, it's going to cause so for instance, in the smooth muscle of the gut, it could cause things like diarrhea. In the skeletal muscle of the arms and legs, it could cause cramps. Okay? So, let's go back to this calcium channel blocker situation. Here's our cell, and we have this calcium channel that allows calcium to go into the cell. If I give somebody a calcium channel blocker, what kinds of side effects would I have? Now, what kind of calcium channel blockers do people use in EMS? Bootcamp, type that in the chat for me. Calcium channel blockers in EMS. Give me some examples. All right, let me help you out. So in EMS, some calcium channel blockers that we use are things like nifedipine, nicardipine. Okay. Sometimes we use things like amlodipine. Oh, actually, amlodipine needs to be here. Amlodipine. Okay. Then we also have other calcium channel blockers that are diltiazem. So that's things like also called cardizem, verapamil. Okay, now how do we classify these kinds of calcium channel blockers? This first section, these are what are called, these primarily work on vessels. So these are what are called vasoselective. And these other ones down here are what are called cardioselective. Okay, so the cardioselective primarily work on the heart, and the vasoselective primarily work on the vessels. There's another fancy word that we use to describe these. The vasoselective ones are called dihydropyridine. And then, so dihydropyridines, and then the cardioselective ones are called non-dihydropyridines. Okay? So those are calcium channel blockers. Now, have you ever been told the side effects of nifedipine, nicardipine, amlodipine, diltiazem, cardizem, verapamil? Have you ever read that? Oh boy, we're in trouble. So you're about to give this patient right now. We got a patient in AFib, A-flutter. We need a calcium channel blocker on board quickly. We need to explain to this patient right now, hey, ma'am, sir, I'm about to give you this drug. Oh, by the way, it's probably going to cause some side effects. These side effects are about this many, 500. Do you want me to give it? Are you okay with it? Now, we should always we should always explain to patients the risk versus benefits of any medication. We never give a medication, or you should never give a medication that you don't understand. Because once that medicine is in their body, we may not be able to do anything for it. Or it may just have to kind of run its course until it's metabolized, right? We may be able to try to neutralize some of the effects, but once it's in there, it's got to be processed. So could you right now on the spot give me, I need like 100 side effects right now, and you don't have time to go read all this stuff. Because, I mean, that's going to take you about 500 articles to know all this. Okay? For me, it took me about $300,000 to find out all this information. But what if we could, based on what I told you so far, Could you figure out the side effects of all these calcium channel blockers right now? You want to try? Let's go. You ready? All right, we got to come up with we got all these calcium channel blockers. I need you to right now give me all these side effects. Well, here, all we got to do is figure out where does calcium normally go. If I block where it normally goes, it's not going to have that effect. So watch this. Let's go. Let's go into the let's go into the atria. If I block it going to the atria, what's it going to do? Watch this. Okay, here's the heart, right? If I block the cells, remember in the atria, we've got the SA node, we got the AV node, and then we got all this musculature. We got all this muscle stuff going on in the atria too. If I block the SA node, what effect is that going to have? If the SA node is the primary pacemaker responsible for setting the heart rate, and if I block the SA node, what effect is it going to have on heart rate? It's going to go down. So we may cause bradycardia. If I block the AV node, same kind of thing. In fact, those would be contraindications for most calcium channel blockers. If they already have a problem with their SA node, i.e., sick sinus syndrome, if they already have a problem with their AV node, we probably don't need to use this calcium channel blocker because we may make that problem worse. But I didn't have to read that. I just know how the cell works. Okay. Now, if I block the cells up here in the atria that are depolarized in the atria, yes, overall, it's still going to have a slower heart rate. But remember, the cells of the atria or the atria itself, when they depolarize, then the atria contract. And when the atria contracts, it dumps blood from the atria down into the ventricles. So if I block it, now I can't get as much blood down into the ventricles. What's that called? That's decreased preload. So I already know it's going to cause bradycardia. It can cause decreased preload. Wow. Okay. What about in muscles? Okay, if I block my skeletal muscles and they can't contract, how am I going to feel if my muscles don't contract? Am I going to be all energetic or am I going to be slow and sluggish? So if I give this calcium channel blocker, it blocks my muscles. Now I'm sluggish. I can't move. If I can't move and I'm sluggish, am I tired or full of energy? Do I move fast or slow? Okay. Do I think fast or slow? Okay. Okay. Do I have muscles in my neck? Yeah, we've got accessory muscles that help us breathe. Remember the scalene, sternocleidomastoid, things like that, right? We've got the trapezius back there, back in the back. So if these muscles are not really contracting well, can I hold my head up or is my head going to be down? Up or down? If the muscles don't work, it's going to be down. Wait a minute. What did I just describe? Picture this person. I've got a person who's slumped over. They can't move. Their head is down. Wait, are there muscles in the mouth? Wait, I've got all kind of muscles in the face. They can't really smile because I need my muscles to contract for me to smile. So I got a mean face. My head's down. I'm tired. I don't want to move. I'm weak. What patient am I describing right now? Who fits all of that? Who's somebody that's tired all the time? They don't want to move. They're weak. They're drowsy. They have a sour looking face. Does that sound like depression? Huh. Wait a minute. Are you telling me, coach, that a calcium channel blocker could cause depression? That's exactly what I'm saying. Now, how many of you have told your patients that, when I give you this calcium channel blocker, hey, it's likely to cause depression? Well, if you've never understood the cell, you may not have made that connection. A lot of books are not even going to mention that as a side effect. Now, if you'll look heavily or if you'll look more deeply in more research articles, you'll find you don't have to take my word for it. Just Google it. Can calcium channel blockers cause depression? Your answer is going to be a resounding yes. But see, I'm able to figure this out just based on the normal physiology of the cell. Is that not pretty cool? Now, but just knowing how it works, watch this. Okay. We said that in skeletal muscle, okay, the muscles don't move. Now I'm going to be tired. I can't move. All of that. Cardiac muscle. It's not, for instance, the SA node gets affected, the AV node gets affected. This is why if they have diseases or disorders of their SA node, like sick sinus syndrome, or if they have some kind of AV nodal problem, maybe if they already have a heart block, I don't want to be given a calcium channel blocker because I can make that heart block worse. They already have first degree block. They already have second degree type 1 winky bop. They already have second degree type 2. They already have a third degree AV block. I don't want to, I need to be very careful using calcium channel blocker. I may need to not use it at all. Now, what if in the smooth muscle? Ooh, wait, where do we have smooth muscle? Watch this. Look how much we can figure out by knowing the basics. Oh, wait, we got smooth muscle in the GI tract. We got smooth muscle. So there's smooth muscle in the uterus. There's smooth muscle in the bladder. Wait a minute. Where else is there smooth muscle? Wait, there's smooth muscle around blood vessels. Where is there smooth muscle? Oh, there's smooth muscle in the respiratory tract. Huh. Wait a minute. Let's take each one of them. If I can't contract the muscles surrounding the smooth muscle surrounding the colon, that means that I can't really move my colon. If I can't move my colon, stuff stays in the colon. Is that going to lead to diarrhea or constipation? Wow. So a calcium channel blocker can cause constipation. In the uterus, I need the uterus to contract. Okay, if I have a pregnant mom who just gave birth, I need that uterus to contract so that I can release oxytocin, cause uterine contraction to prevent postpartum hemorrhaging. What if they're already taking a calcium channel blocker and they go into labor? Could it affect their uterus being able to contract? And if it cannot contract, could they potentially bleed to death? Wow. What about the bladder? Wait a minute. Okay, is there smooth muscle in the bladder? Absolutely. In fact, that bladder is actually the muscle there is called the detrusor muscle. When the detrusor muscle here, this is what it looks like. It's like this. So we got the bladder, and then coming from the bladder, we've got the urethra, and then you're going to pee it out, right? Okay, and then coming to the bladder, we've got these ureters, and then that's going to come from the kidneys, right? Okay, now, so when this detrusor muscle, so we have this muscle right here, this detrusor muscle of the bladder, when it contracts, that's what allows you to pee. So in order to pee, the detrusor muscle has to contract, and then the internal urethral sphincter has to relax. That's what when this thing squeezes, and then we push urine out, this guy right here has to relax, and then the urine comes out. But what if I give him a calcium channel blocker and I cannot contract this bad boy? What's going to happen? If I'm not able to contract the detrusor muscle, what happens to my urine? Because when it contracts, that's what helps me pee. If it cannot contract, what's going to happen? Now I'm, oh, so what will we call that? Oh, that sounds like urine retention. That sounds like urinary retention. Wait, you're saying a calcium channel blocker could cause urinary retention? Absolutely. Okay. Oh, what about the respiratory tract? There's smooth muscle. All right, check this out. Okay, let's go to the respiratory. So we've got our trachea with our cartilaginous rings here. We've got our left and right main stem bronchus that meet in the at the carina, and then these are going to come into smaller bronchioles, and then we're going to get to those terminal bronchioles. Then we get to our alveoli. Now, but there's also smooth muscle surrounding this respiratory tract. What if this smooth muscle doesn't really contract? But part of when it contracts, That's what helps us move mucus out of our respiratory tract. Well, I need it to contract to move the mucus. If I block it with a calcium channel blocker, now that muscle doesn't contract. What happens to the mucus? Ooh, wait a minute. So the mucus is going to stay. So, am I more likely to have infections or less likely to have infections if I have something trapped in there? Ooh, so I'm now more likely to have respiratory infections because I gave a calcium channel blocker. Okay. Is this pretty cool? Okay. So let me show you what. Oh, let me go to this other thing about cell signaling. Did that show up? Yeah, cell signaling. Now, in order for, let's say, things like in the pancreas, in the pancreas, we've got here, let me clear some space. In the pancreas, we're almost done. Don't confuse this with the liver. This is the pancreas. We have this cluster of cells in here, the pancreatic islets. There are three types of cells in here. We have alpha cells, we have beta cells, and we have delta cells. We have delta cells. Okay. Alpha cells are what produce glucagon. Beta cells are what produce insulin. Delta cells are what produce somatostatin. So these are all hormones. In order for the pancreas to release insulin, I must have calcium. If I give a calcium channel blocker, now the pancreas cannot secrete insulin into the bloodstream. If I cannot secrete insulin into the bloodstream, what's going to happen to the blood sugar? Because the job of insulin is to make the blood sugar level come down. But if I don't have any insulin in the bloodstream, what's going to happen to the blood sugar? It's going to increase. So now we can have increased blood glucose level, also known as hyperglycemia. So let me show you what a calcium channel blocker can do. A calcium channel blocker can affect the SA node. It can affect the AV node. That's going to affect heart rate. We don't want to give it it would be contraindicated if they already have problems with those. It can definitely slow down heart rate. It can affect all muscle contraction. It can affect movement in all muscles. It can affect in the GI tract. It can cause constipation. It can affect the uterus. In the bladder, it can cause urinary retention. In the blood vessels, if those muscles don't contract, then the muscles relax surrounding the blood vessel. Now it's going to lead to vasodilation. If I vasodilate, now I can have, what's that going to do to my blood pressure if I widen the blood vessel? Is the blood pressure going to go up or down if the pipe gets bigger? Aha, so now I can cause hypotension. Okay, if I can't contract the smooth muscle around the respiratory tract, now I'm more likely to have respiratory infections. Look how many things. Oh, and we also mentioned when it comes to hormones like insulin, we mentioned things like it could also cause hyperglycemia. You have never read probably half of this stuff, but look how much we were able. Now, obviously, it took me a minute to explain everything, but imagine if you were to practice doing this on a regular basis, how much you would know just by knowing the cell. Now, what did you learn today? That was a lot. So we're ending now, but what did you learn today? Yes. Not only will this help you take care of patients, but imagine your own family if they're taking medicines, right? All you got to do is pick up the pill bottle and say, "Ooh, wait, this is given every 4 hours." Oh man, okay, it's given every 4 hours. I know it works quickly. Okay, that's why we have to give it so often because they run through it so fast. That medicine is given every 4 hours. I don't care what the name of it is. What do you know about it now? Can you just repeat that without me showing you on the screen? What do you know just because the drug is given every 4 hours? I want to see what you can do. All right, speak up for me. Okay. Okay. If we need to figure out, okay, is it going to be an acid or a base? So if they have too much acid and it's affecting the kidneys, how could I help it out? Fluids. If the fluids don't work, I'd probably switch to what? Look at this. This is awesome. Okay. And then is it a does it easily cross membranes or have a hard time? It has a yes, they're large molecules. They have a hard time crossing molecules. I mean, crossing membranes. And the other reason, think about it, it's a water soluble medicine. It's a water soluble drug, right? And the membrane is mostly made of fat. So when the water comes to the fat, it repels it because water and fat don't mix, right? That's why it has a hard time crossing. That's another reason it has a hard time crossing the membrane. Is it okay if it's a water soluble drug metabolized by the kidney? It's large. It's going to behave like an acid. If they have too much acid, we're going to neutralize it with fluids. If fluids don't work, we're going to go to bicarb. Now, is it going to easily? If it doesn't easily cross the membrane, is it likely or less likely to cause things like confusion, altered mental status? Less likely. Okay. Okay. If it's is it more or less likely to cause things like hepatitis, myositis, pancreatitis? Okay. Now, what if it's a drug like amiodarone, for instance? If it's given in pill form, it's often given once a day. Oh, I said once a day. What do we know about amiodarone? Just because I said it's given once a day. Lethargy, confusion, mental dullness, sleepiness, uh, slow arousal, things like that, right? Memory lapses, lots of things. Okay, can amiodarone easily damage the pancreas? Yes. Okay. It can. So now it can cause pancreatitis. It can cause hepatitis. It can cause myositis. It can cause if it gets in any membrane, it could damage the cells of that organ and cause organ damage to that organ. Okay. Um, For instance, amiodarone is one of the most dangerous drugs we ever give patients because of the very reason we just talked about. It has a high volume distribution. It's small molecules that go everywhere and they can wreak havoc on everything. For instance, remember amiodarone is a class 3 drug that affects sodium channels, potassium channels, calcium channels. So wherever there are calcium channels, it can have those effects. Wherever there are sodium channels, it can have those kinds of effects. Wherever there are potassium channels, it can have those kind of effects. But amiodarone is one of the big drugs that's known to get, for instance, it crosses the membrane in the lung, in the tissue of the lung parenchyma. It makes the tissue scar. So now we have scar tissue in the lungs. That's what happens in pulmonary fibrosis, for instance. Now the lungs are stiff. If your lungs are stiff, is it going to be easy to breathe or hard to breathe? It's hard to breathe. And that's exactly what happens in pulmonary fibrosis. You have a restrictive lung condition where now you can't get air in. And when you can't breathe in, is your face going to be nice and pink or you're going to be more cyanotic? Okay. So one of the big effects of pulmonary fibrosis is cyanosis. So we call that the amiodarone blues because when you take amiodarone for a long period of time, it can cause you to turn blue. Okay. All right. And then, for instance, one other thing, this is another reason that drugs like amiodarone are so dangerous. Do you know what the half life of amiodarone is? No idea. That's okay. Do you know that when you give somebody amiodarone, or let's say we give it to them in the field or hospital, whatever, a drug like that, this is why you want to be careful using these kind of meds and really understand them. Do you know that one drug, for instance, let's say they're in Postless VTAC or VFib, and we give them amiodarone following our ACLS protocols. Well, let's say we give them that initial bolus dose, and then we'll maybe repeat the dose, and then finally we get them back, and now we're going to hang an amiodarone drip, and then so we're going to mix up our amiodarone drip. We're going to run that. That's going to run for a few hours. Do you know the effects of it, though, will linger sometimes 8 weeks, 11 weeks, stuff like that. So months, 2, 3 months after you've given it, it's still having an effect. Okay. So I hope this made sense today. I hope you learned something. And here's what I'm gonna do. I'm gonna go ahead and end this for a moment. Hang on, just stay where you are. All right, so boot camp, that's it for now. Uh, we will have our next session on Tuesday for those of you in boot camp. Everybody else, this will conclude the meeting tonight. And I want Lisa, I want you to stay there for just a second. So I'm gonna end it on my side, but you stay where you are.